And we're going to do history and physical examination of the chronic pain patient. I heard Anand mention this about 30 times in his talk, which is very important, history and physical examination. It's a lost art these days. It's a lost art. But I want you guys to re-look at this, because history and physical examination will give you 75% of your diagnosis is made by history and physical examination, even in pain management. So please, examine your patient appropriately. And that's what we're going to talk about. I'm going to go forward with this. Pain, we talked about what pain is. I'm not going to waste my time with this. So what is obtaining a good history is, right? You have to obtain a good history from a patient when he walks into your clinic. Any kind of complaint, but we are talking about pain here, but any kind of complaint, a history is worth its weight in gold. So obtaining a meaningful and relevant history in a chronic pain patient provides clues to the origin and cause of pain and contributes to a significant part of the diagnosis. So you have to have a meaningful and relevant history. Let's start with the chief complaint, right? The first thing that you write in your chart is a chief complaint. So what is the chief complaint? The reason why the patient is seeing the physician is the chief complaint. Why are you here? Well, the other doctor sent me, right? So that's not a chief complaint, but that's what they say. That's what they tell you, the other doctor sent me here. Well, why did the other doctor send you here? Well, then so you have to get to the chief complaint. Always document it in patient's own words. Chief complaint is not, disc herniation is not a chief complaint, right? Disc herniation, I have a herniated disc. No, that's not a chief complaint. No, so you have to say, where is your pain? I hurt in my lower back. That is a chief complaint. Low back, neck pain, arm pain, headaches. I have a headache. That's a simple chief complaint. My back hurts, my neck hurts, my arm hurts. That's what you need to document in chief complaint. Next, you come to the history of present illness. You start from the history of pain, from when it started to the present date. You have to get it all the way. When did the pain start, and then what has happened from that time till you are seeing the patient? That is what you need to ask. Then the pain history begins with the first time when the pain started. So go back again, keep asking them till you get to the point where the pain actually started. How did the pain start? When did the pain start? Why did the pain start? Where did the pain start? And then how has it progressed with time? And what was done before they came to you? Did they try physical therapy? Did they try medication? Did they try chiropractic therapy? Whatever. Did they have a back surgery? So you have to ask every single question, and every single question is very pertinent. So please find out about all these. How, when, why, where, and how has it progressed? And then the pain diagram, guys, is very, very, very important. All pain history has to have a pain diagram. So usually all pain history forms have this diagram. So put a diagram on your sheet and let them mark where the pain is. If you see the diagram on the left, what do you think that pain is? The pain marked with red. What do you think that pain is? It's the patient. Pardon? What pain is that? Fibromyalgia, maybe? They've shaded their whole body, right? So that means it is diffuse pain. So it probably is fibromyalgia. So that's how important this is, they are telling you. And then sometimes a patient draws you an S1 nerve root on that, right? They draw a straight line from the back, down the back of the leg to the foot. You don't need a better diagnosis than that, right? So they've almost drawn you an S1 nerve root on the picture. So there you have your diagnosis right there. So that's why the pain diagrams are very important. They tell you a lot. And then characteristics of pain are very, very important. I heard Anand mention this. I'm going to say this again. Location, ask the patient to show where the pain is, because there is so much of confusion. My hip hurts. Well, show me where the pain is. They point here. That's not your hip. That's your back, right? Where does your hip hurt? Where do you get pain when you have hip pain? Anyone? Where does the hip hurt? In the groin, anteriorly, right? Hip pain is anterior. So they don't show your back, but they say my hip hurts. Well, guess what? Show me where your pain is. Quality is very, very important. Is it constant? Is it intermittent? Is it dull? Is it aching, sharp, stabbing, pinching, burning, electric? Feel like being beaten up. Every single adjective here is important. When it burns, it is neuropathic, right? When a pain burns, it's neuropathic. When it's electric-like, it is neuropathic. When it's dull, aching, it can be a lot of different things. You can at least decipher if it's the nociceptive pain or neuropathic pain, right? Nociceptive pain is more dull, aching. Neuropathic pain is sharp and burning, electric-like pain. So the descriptors are very, very important. Then you ask for radiation. Where does the pain travel to? It is the single most important question that you ask in back and neck pain, right? Your back pain, you have back pain. Okay, does it go down your leg? Makes a big difference. That is radicular pain. If you have neck pain, does it go down your arm? Makes a big difference. It's radicular pain again. So the radiation of the pain is very important. Well, you have your loin to groin pain, right? What is loin to groin pain? Renal colic, right? So loin to groin pain. So it radiates from the back all the way to the front. How long has the patient had pain? And measure the intensity of pain. There are several ways of measuring the intensity. There is VAS, right? Visual Analog Scale. A lot of people confuse VAS with the NRS. What is the NRS? NRS is the numerical rating scale where you ask the patient what your pain is on a scale from 0 to 10. 0 being no pain and 10 being the worst pain. What is your pain? And they will give you a number, 9, 10, 8, whatever. Visual Analog Scale is when you actually show the patient the scale right there, visual, right? And you then ask them to mark on the scale where their pain is. That is the visual analog scale. And there are plenty of other scales, behavioral pain scales. I'm not going to go into all the scales, but remember that you have to ask for the intensity of pain using one of these scales. Characteristics of pain. What are the palliative factors? What makes the pain better? What makes the pain worse, right? Going upstairs or or downstairs, your knees hurt, right? That is a typical sign and symptom of osteoarthritis. So what hurts? Lying flat on my back hurts. What does that indicate? Lying flat, can you tell me? Lying flat on my back hurts. It indicates facet-mediated pain, right? Because you're extending your spine when you're lying flat. So it can be facet. I'm not saying it's always facet pain, but it can be facet-mediated pain. How does the pain affect activities of daily living, sleep, social life, hobbies? And more importantly, what are the associated factors? Do you have any tingling or numbness? Then you're going in for radiculopathy, right? Back pain with tingling and numbness going down the leg is lumbar radiculopathy. Neck pain with tingling and numbness going down the arm is cervical radiculopathy. Do they have allodynia? What is allodynia, guys? Non-painful stimulus causing pain. Hyperesthesia is just heightened perception, right? Motor symptoms, weakness. If there is motor weakness, if there's a foot drop, you know it is radiculopathy, right? There is a nerve root being compressed. Spasms. Phonophobia, photophobia are giveaway signs of what? Migraines, right? No, phonophobia, photophobia. If they say, then your mind goes automatically in the direction of thinking that may be a migraine. No, lacrimation, tinnitus, visceral abdominal pain. Do you have nausea, vomiting, constipation, diarrhea, bowel or bladder incontinence? Very, very important. Sexual dysfunction. Then you ask for, if somebody comes with multiple joint pain, do you have swelling of those joints? Do you have any deformities? In rheumatoid arthritis, what do you see, right? You see deformities. You see swelling. And then do you have any pedal edema? Are there any sympathetic manifestations, which is very, very, very important in diagnosing maybe CRPS or any sympathetically maintained pain? How's the skin look? How's the color, temperature, hair or nail changes? Very, very important in sympathetically mediated pain, SMP. Psychiatric factors. Is there depression? Do you have any suicidal thoughts, anxiety with your pain? Having finished this part of your history, then you go to past medical history, complete history of all medical problems, no matter what. Every problem is relevant. And past surgical history, what surgeries have you had in the past? It doesn't matter, not pain-related surgeries, any surgeries. Medications. Complete list of current and previous medications, including over-the-counter medications. These days, people are taking so many supplements, right? So many supplements. They take ginger, they take garlic, they take this, that, and the other. Everything matters. So you need to ask them, because some of them are blood thinning. You know, some of them thin your blood. So you need to make sure you know every single supplement that they are taking. Allergies, of course, you know. Do you have any allergies, side effects to medications, foods, latex, or any other substances? Then we come to, after you finish your past medical surgical history, allergies, then you go to social history. Very, very important, guys, very important, because what is the patient doing? I heard Murli say, if that guy goes and, you know, carries suitcases on his head, guess what you're going to do? You can do all the injections you want, and if that guy is going to continue doing it, then you're not getting anywhere. So social history is important. What is your occupation? What do you do for a living? I sit in the front of a computer for 18 hours a day. Guess what? You're going to have neck pain, and so that's very important. Working conditions, hours, what do you do? And personal living conditions, where do you live? Daily routine, you know, marital issues, social, family situation, pregnancy. Pregnancy is a big thing, right? You have to ask. You know, if it is a woman of childbearing age, it behooves you to ask if there is any chance of pregnancy, because if you're planning for any interventions, you have to be careful. So you need to find out all of this. Family situation, how many children at home? Habits, smoking. You know, smoking is the biggest thing. Why does smoking matter to us? It matters a big way. I know of neurosurgeons who will not operate on backs if you smoke, right? Because smoking, what does it do? It cuts off the blood supply to the disc. So there's no point in operating on a disc when you smoke. So smoking is very important. Alcohol, illegal substance use. So what are your hobbies? And family history, guys. Family history is so important, particularly about inherited disorders. Rheumatoid arthritis, you got to take a family history. Rheumatoid arthritis, you know, there's got to be some history in the family about rheumatoid arthritis. Ankylosing spondylitis, any autoimmune disorders, all of that matters when you ask for family history. Review of systems, constitutional, weight loss, sleep disturbances, fever, is very important. You know, weight loss is important in cancer. Sleep disturbances, fever, inflammatory reactions, and skin, rash or eruptions. The head, eyes, ear, nose, and throat. Do you have any changes in vision, hearing, taste, smell? Cardiovascular system, do you have chest pain, dyspnea on exertion, respiratory, cough, shortness of breath, dyspnea on exertion? Do you have heartburn, nausea, vomiting, constipation? So you just run through the systems and review them. That's the point of this slide here. Genitourinary, do you have bladder incontinence, sexual dysfunction, musculoskeletal pain, spasms, deformities, neurological? Do you have any seizures? Seizures are very important to ask for. Sensory or motor disturbances, phonophobia, photophobia, psychiatric, and hematologic. Easy bruising and bleeding are very important. If you see bruises, then you need to investigate it further. Now comes the physical examination. The history part is done. 50% of your diagnosis comes through your history, at least anywhere between 25 to 50% of diagnosis. By the time you finish history of a patient, you should have already formed a part of your diagnosis in your brain. Okay, this may be lumbar radiculopathy that I'm looking at. So you should get, at least start forming some kind of impression in your mind. Physical examination begins with observing how the patient walks in and ends with noticing how the patient walks out. So that is very important. But how many of us can do that? We are all sitting in our chambers, and sometimes we don't see it, but it's very important for us to see how the patient walks, because there are gaits that you can distinguish. There's a hip gait, there's a knee gait. Patients with hip pain walk in a different way. Patients with a knee pain walk in a different way. So as they walk in, you can say, yeah, that comes the hip right there. There comes your knee right there. So that's what you need to watch when the patient walks in. Physical examination is always done with the patient undressed and preferably in natural light. How many of us do it? Not possible because of so many issues, so many social issues. Female patients, it's very difficult to ask them to disrobe for a lumbar spine examination. I understand that, but you got to break those social barriers. If you don't disrobe them, you can miss so many important things. You can miss huge things if you don't undress a patient to examine them. So, and preferably in natural light. You can miss jaundice and stuff like that. So, again, lost art, guys. Inspection, palpation, percussion, auscultation are the basic tenets of physical examination. So, do it. Touch your patient, feel your patient. That is the only way that you're going to be a better clinician. So, do the examination. Stress is on a focused examination of the painful area part of system. If they come with low back pain, don't spend a lot of time examining other systems. Focus. Focus on your back and then hone in on the back. Yes, you have to do other examination also, but focus on the back more than the other systems. Physical examination transforms and sums up the clues obtained from the history to a more objective and concrete basis of diagnosis. So the impression that you have formed in your history will now take a concrete form once you finish your physical examination. Vital signs, of course, are important. That's why they're called vital signs, right? Temperature, pulse, respirations, blood pressure. General examination, height and weight, that's normal. And the most important thing is, do they have any behaviors related to pain? How are they sitting in the chair? Do they have to keep moving all the time? You know that they are in pain. That tells you. And then restless, changing positions frequently. What is their effect? How do they present you? Do they tell their pain is a 10 and they're smiling at you? Then that's not right, right? So they can't smile at you with a pain of 10. So affect is also very important. Posture, asymmetry. Is there any asymmetry? Kyphosis, scoliosis. Deformities, there are some deformities that are so easily visible, like rheumatoid arthritis. You can't miss rheumatoid arthritis. So, skin, is there any changes in the color? Rash, scars, lesions, ulcers, petechiae, bruises, so very important, guys, because if you look at sympathetically maintained pain, a CRPS limb, it's swollen. The color is changed completely. So, you know all that just by looking at the skin. Swelling and edema. HENT, I'm going to just brush through this. You look at the face, scalp, pupils. Now comes the neck examination. If somebody comes with neck pain, then you focus on the neck examination. Inspection, the same thing. Always follow the same rule for your examination of any system, any part of the body. Inspection, palpation, percussion, and auscultation, right? These are the 4 things that you do. Why would you auscultate a neck? Would you auscultate a neck? Why would you auscultate a neck? For any bruise in the carotid artery, right? Maybe. So, yes, you do auscultate a neck. So you have to go with each step. Inspection, are there any scars, swelling, deformity, symmetry, posture, muscle spasms, range of motion? You ask them to flex, extend, rotate, and side bend and tilt. So you examine the range of motion in the cervical spine to see whether it is limited or they have full range of motion. If it is limited, how much limited is it? And if is pain limiting it or is a muscle spasm limiting it? So you have to differentiate that. Palpation is very important. You palpate. What do you palpate in the neck? You palpate the muscles and see if they have spasms. Do you have trigger points, right? Trigger points you can palpate. And if there is midline tenderness, you're thinking about more discogenic pain, right? Midline tenderness. And then if it's paraspinous tenderness, it is more muscular in nature. So that's what you need to palpate. Sperling's test. What is Sperling's test? Compression of the neural foramen, test for cervical radiculopathy, right? So what you do is somebody has symptoms going down the arm with tingling and numbness, and they have neck pain. That is radicular pain. So you do a Sperling's test. How do you do the Sperling's test? Just ask them to side bend to the side of their pain. What are you doing by doing that? You're closing the foramina, right? You're closing the foramina. You're producing more pressure on the nerve root. And if they say their tingling increases, there you go. That's a Sperling's positive test. It's similar to your straight leg raising test in the lower back. It is similar. I'm not saying it's the same, it's similar. The mechanism is the same. I'm not going to, I mean, these presentations are all available, guys. You know, if you ask, we can give you the presentations. I'm not going to go through these YouTube videos. You know, plenty of YouTube videos for Sperling's test. Just type Sperling's test in Google and you can get all these videos. Myelopathy is very, very, very important, right? You know, you have to test for myelopathy. Muscle weakness, ataxia, these are the signs. And sometimes they are hyper-reflexic. So tests for myelopathy are very, very, very important. And like Dr. Joshi has mentioned, you have to identify who is not your patient. People with myelopathy, don't stick needles into them. No, you got to send them to a neurosurgeon. So that's what you have to be careful about. So you need to do your test for myelopathy, right? Chest examination, once again, go accordingly. Never miss a trick. Inspection, palpation, percussion, auscultation. Always follow those 4 golden rules, always, for any system. Inspection, palpation, percussion, auscultation. Heart, the same thing again. So just putting a hand on their pulse can tell you so much. And the whole system of medicine, Ayurvedic medicine, is based on just identifying what is wrong with the pulse. So that's how much you can learn from just putting your hand on the pulse. The abdomen, you know, same thing again, inspection, palpation, percussion, and auscultation. Why do you percuss the abdomen? What do you get from percussion? Yes? Why do you percuss? If you get a tympanic note, what does that mean? There's air in there, right? So, yeah, you can diagnose peritonitis and stuff like that, and rebound tenderness. So percussion is very important. Palpation, rebound tenderness is important. So auscultation, bowel sounds, of course. Are they sluggish? No, can you feel the bowel sounds? Are they hyperkinetic bowel sounds? So everything matters. External genitalia and pelvic examination is very important, and that's another big issue while examining female patients. You know, it's an issue they will not, they're very uncomfortable, but if it is required, you have to do it. Coming to the spine examination is very, very important in pain management. So again, the same thing, inspection, scars. Do they have a back surgery? Do they have a scar? Swelling, is there swelling? There is deformity, symmetry. Look at them. Step back and look at their chest and their spine. Is there kyphosis? Is there scoliosis? Is there muscle spasms? And what is the range of motion? How far they can bend forward? How far can they go backward? Rotation, side bending. And is there any pain with the range of motion? Palpation, again, the same thing. You push on the spine. If you push on the spine, if there's midline tenderness, 2 or 3 different things. They can have a vertebral compression fracture. Midline tenderness is very positive. Or they can have a disc related pain, midline tenderness is there. So paraspinous tenderness is more like muscle tenderness. There can be trigger points. Kemp's test is very simple. You extend and rotate the spine. So what are you doing there? You're stressing the facets, right? You're stressing the facets by doing that. And that is facet-mediated pain. Straight leg raising test, very simple. No, raise the leg like Anand said before. So 30 degrees, 45 degrees, they have pain. You're stretching the nerve root in the foramen, and then you can identify radicular pain. I'm not going to go to the YouTubes and stuff like that. We don't have time. So joint examination is very, very, very important in pain management, because you will have a lot of people walk in with gout. You will have a lot of people walk in with rheumatoid arthritis, osteoarthritis. So joint examination is very important. Are there deformity? Once again, inspection, same thing. Deformity, swelling, symmetry, range of motion. All motions of the joints are tested. Every single motion at a given joint is to be tested. If the shoulder needs to be tested, it has so many different range of motions. Abduction, extension, rotation. So you have to test every single movement at every joint that you examine. Palpation is very important. Again, temperature. If a joint is inflamed, it is hot, right? So palpation is very important. And muscle spasms, motor strength. You test the motor strength also for joint. What do people have in rheumatoid arthritis, guys? They don't have any hand grip, right? It's not because of any motor weakness in their hands, but because of the joint swelling, they can't really they don't have good motor strength in their arms. So that's a giveaway sign for rheumatoid arthritis. Limb examination. If you're looking for radiculopathy or if you're looking for vascular causes, your limb examination is very important. Inspect skin, color, hair, nail changes, edema. You know arterial insufficiency when you see there is hair loss, right? There is hair loss on the limb. It's swollen, it's red. Then you know that is arterial insufficiency right there. You can't palpate the pulse. So inspection, of course, just with inspection, you can see that there is a hairless limb which is swollen you're looking at arterial insufficiency. Palpation, you always palpate peripheral pulses, and especially in a limb, you have the two important pulses that you're going to palpate are what? Dorsalis pedis and posterior tibial, right? So because that will tell you how far down they have blood supply. So that's very important. So these are the two pulses that you palpate. Muscle tone, strength, and then sensory examination, you do allodynia, hyperesthesia. If they have allodynia, they will not let you touch their limb. As soon as you put your hand to examine them, they will withdraw their limb. You know that they have allodynia when they do that. So that is in CRPS, they do that. Hyperesthesia, heightened sensation. Hypoesthesia, lowered sensory perception. Paresthesia, altered sensory perception. Anesthesia dolorosa. What is anesthesia dolorosa? A place where they don't feel sensation but they have pain, right? That tells you that is neuropathic in origin. Motor tone and strength of muscles is very, very, very important for you to test. Every single muscle group has to be tested in the affected area. If they have radiculopathy, they can have a foot drop. They may not have a foot drop, but they have significant weakness when you examine them. They're just dragging along, but when you examine them, you know they have a motor deficit, then you know you're dealing with radiculopathy and more serious issues which need to be addressed in a different way from, those are the red flags that the other speakers were talking about. So, Hohmann's sign. What is a Hohmann's sign? What do? You dorsiflex the foot, right? If they have pain, then they may have a thrombus in the calf. So that's Hohmann's sign. That's very specific for deep venous thrombosis. Neurological examination is very, very important in pain management. Pain management, neurological examination, I cannot stress the importance of a good neurological examination. Romberg's test. What is Romberg's test, guys? Huh? So you ask them to close their eyes. So what happens? They sway, right? So why do they sway? You need three things to keep your balance, right? You need three things to keep your balance: proprioception, vision, and vestibular apparatus. So when you're closing their eyes, what are you doing? You're taking out one. You're taking out one of the three. Then you know how the other two are working, right? That's the point. That's the point of doing Romberg's test. Higher mental functions, memory, short term, long term. How is their mental function? Are they awake? Are they alert? Are they oriented in time, place, and person? And so that's what you need to look at. Cranial nerves, most of the cranial nerves can be tested while talking to the patient. If a patient is talking to you, guess what? Mostly 1 through 10 are intact, right? If they're talking, they're making sense to you. That's all you need. If you go through all your cranial nerve tests, that's what you have. You need articulation, you need everything, and if they're moving their eyes, you've tested your 3, 4, and 6 already there, and if you want, you can ask them about the sense of smell. You go back to your olfactory, and so on and so forth. So again, I'm not going to go through these videos again. There's plenty of time that you can do. We don't have time, so I'm kind of going forward. Motor testing, deep tendon reflexes, and sensory testing. These are very, very important. Again, simple tests, guys. Motor test, push, pull, and kick and lift. You have tested all the flexor and extensor groups of muscles in the upper and lower extremities, right? Push and pull, kick and lift. So you have tested flexors and extensors in one movement or two movements. So very simple. You can do this test. Grade strength. How do you grade strength? I'm not going to go through all this. This is pure physiology. So, 0, 1, 2, 3, 4, 5, movements against gravity. So the bottom line is that you have to identify any deficits. That's the bottom line here. So reflexes, tap, tap, tap. Again, a lost art, but I will ask you to do this. It's a lost art, but it's very important. Myelopathies, very subtle, science. You can easily identify by doing very, very simple tests. I'm not going to go through. This is a physiology class, very brisk. You can remember all that. And sensory examination is one of the most important things that you do in pain management. You map your dermatomes, you know your dermatomes, C1, C2, C3, whatever. You just do a simple test. You can test them using different modalities. You can do temperature, you can do sensory, you can do light touch, you can do discrimination, you can do pinprick. All of that can be done. Vibration and temperature. And then in addition to this, chronic pain patients should be tested for allodynia, right? Allodynia is a giveaway sign for neuropathic pain. So you need to test for allodynia. Painful response to a non-noxious stimulus like touch is allodynia. Hyperesthesia, increased sensitivity to any stimulus. And hyperalgesia is increased sensitivity to pain. A pain stimulus elicits an exaggerated response, that is hyperalgesia. Anesthesia dolorosa, we talked about it. Areas of decreased sensation to touch, but they are painful. Paresthesia is abnormal sensation, tingling, numbness, and pricking. So you've done this physical examination. Now you come to one more, labs and imaging studies. Review all available imaging studies and labs and request for any new or previous studies. Let me tell you a story about these labs and imaging studies. One of my patients walked in, actually quite a few of them. Walked in and said, did you look at my MRI? I said, no, I didn't look at your MRI. So then, are you not going to look at my MRI? Say, I need to examine you first, and then I'll look at your MRI. They said, no, you need to look at my MRI. So I told them, I can treat your MRI very nicely, or I can treat you. You tell me which one you want me to treat. So that's the point. The point is, imaging studies are important, and diagnostic studies are important, but let that not be the only way you diagnose patients. So imaging in diagnostic modalities most useful in pain are X-rays. I'm not going to go through all this. Anand's done that, and then we have a lecture coming up on imaging studies, so I'm not going to go through this. CT scans, MRIs, myelography, discography, ultrasound Doppler. Why do you do ultrasound Doppler? For arterial insufficiency, right? When somebody has pain going down the leg, it's just not radiculopathy, guys. It can be neurogenic claudication, it can be vascular claudication, right? Or radiculopathy. So you have three differential diagnoses there. So you'll be best served by doing a simple Doppler test. It's non-invasive. And you can see, if they're a smoker, guess what? You have to think about vascular claudication if they're a smoker. EMG, simple test, non-invasive. The only problem with EMG is it's painful, so you got to be careful ordering an EMG. In a patient with CRPS, I would not order an EMG because they will curse you for getting an EMG done. So, and labs, RF factor, you don't need any other lab. One single RF factor can make you a diagnosis of rheumatoid arthritis, CRP, lupus, ESR, uric acid, gout. You diagnose gout in the lab. So you have done your history, you have done your physical examination, you have ordered your test. Now comes the most difficult part in our, in everybody's, in our clinical part, the assessment and plan. So you have to assess what the patient has. Now, then you have to give them a plan and you have to treat them. So that's what is assessment and plan. This is my favorite saying: when you have eliminated the impossible, whatever remains, however improbable, must be the truth. Right? Sherlock Holmes, sign of 4. Sign of 4. How many of you have you read Sherlock Holmes? Okay. Read it. All of you, read it. Because that is the basis of diagnosis. You know who wrote Sherlock Holmes? Sir Arthur Conan Doyle. Who was he? He was an ophthalmologist. He was a physician. And he made all Sherlock Holmes' observations based on his observations. So, if you want to be a good physician, guys, read Sherlock Holmes. And as far as I'm concerned, he's the best detective in the world. I love him, but more importantly, we base a lot of our diagnosis on what he said. When you have eliminated the impossible, whatever remains, however improbable, must be the truth. So you have to eliminate the impossible first. And then whatever remains, however improbable, must be the truth. So just keep this in mind, and I would encourage all of you to read Sherlock Holmes. It's very interesting. And if not for this, at least to enjoy something, you can read Sherlock Holmes. Now, the combination of history and physical examination, diagnostic imaging studies, and labs should enable the clinician to come to a diagnosis assessment, or at the very least, differential diagnosis. So you have to be able to come to a differential diagnosis at the very least, or a diagnosis after you have done your history, your physical, and your labs and imaging studies. The emphasis is on trying to identify the source and nature of pain. Once again, the same things that my predecessor speakers have said, Murali, Anand, you have to identify where the pain is coming from. You have to identify the pain generator, right? Is it in the anterior compartment? Is it in the middle compartment? Is the pain coming from the posterior compartment? Whether it is in the neck or in the back, it doesn't matter. You have to identify where the pain is coming from. And if you can't identify, you cannot treat. As simple as that. So you just can't say you have back pain. You have to be able to say where that back pain is coming. Is the back pain coming from facets? Is it coming from muscles? Is it coming from a disc? Is it coming from the vertebral body? So you have to be able to say where the pain is coming from. Identify both the source and nature. What is the nature? Is it nociceptive or is it neuropathic? So you have to be able to identify between these two. Example. A patient with back surgical evaluation. So that is your plan for this patient. And then that is for the discogenic part. What about the radiculopathy? What do you want to do for the radiculopathy? Patient will benefit from physical therapy, lumbar epidural steroid injection, surgical evaluation, and medications like gabapentin, because you have diagnosed them with radiculopathy, and guess what radiculopathy is? It's a neuropathic pain, right? So you treat them with neuropathic medication. So gabapentin, NSAIDs, oral steroids, or opioids. So this is what you're going to and then long-term, continue back exercises. Back health is very important. That is the single most important thing that you have to stress. Interventions will help them to some extent, but overall, on a long-term basis, you have to stress on back health, back exercises, and keeping yourself healthy. Back health is a very we don't stress enough on back health. So you need to stress on back health. And then exercises, yoga, whatever kind of exercises are suitable for that one particular patient, you have to stress on that. NSAIDs as needed only, and surgical evaluation if patient develops sensory or motor deficits or bowel or bladder incontinence.